Hello, everyone. Thank you for joining today's 2018 QCDR Measure Workgroup webinar. CMS will provide an overview of the development, criteria, and evaluation of QCDR measures. After the webinar, CMS will take questions as time allows. Now I will turn it over to Robin Williams, a CMS contractor specializing in QCDR measure development.
Thank you, and thanks to you all for joining this QCDR Measure Development webinar for the MIPS program. I'm Robin Williams from the Practice Improvement and Measures Management Support, or PIMS team, and will be one of today's presenters. Next slide, please. Our disclaimer: Medicare policy changes frequently. The information provided during this presentation is intended to be a general summary. It does not take the place of written law or regulations. We encourage you to review the specific statutes, regulations, and other interpretive material. Next slide, please. Here's the agenda for our webinar. The intent of the webinar is to provide opportunity to learn what kind of QCDR measures will likely be approved for MIPS. With me is Dr. Green from CMS's Center for Clinical Standards and Quality, Stephen Slega from the Quality Payment Program, Jocelyn Myers, who's a colleague of mine on the PIMS team, will be your presenters today. Dr. Green will get us started, then Jocelyn, Stephen, and I will tag team through the rest of the presentation, concluding with a Q&A. Dr. Green, would you get us started, please?
Yes, thank you. Robin, folks, can you hear me okay?
We can hear you.
Hello? Okay, great. Well, welcome, everybody. So glad you all could join in. Looks like we have quite a few folks on the call. I'm glad that there's this level of interest, certainly, in the measures. This is, I'll say it's an encore, updated encore of our earlier measures workgroup webinar. We have met with several QCDRs to this point, and between the measures workgroup as well as the individual meetings we've had, so far the feedback has been good. And we're encouraged by that to try to make this process better and easier for the QCDRs as we move forward. Next slide, please. Okay, so this is just going over our strategic vision and measure development priorities. We do seek alignment across federal and state and private programs, certainly where we're able to do that. We are trying to promote efficient data collection. We realize that in some instances, in some methods of collection, there can be burden associated with this, and we're trying to minimize and reduce the burden as much as possible. We are also trying to balance the individual as well as group provider accountability. We do think that the measure should, of course, address clinical gaps in care and support evidence-based medicine, as well as engaging patients and their clinicians in care delivery. So clearly there's no good reason to measure something that is already being done 100% of the time. We're looking at this program as an opportunity, one, to confirm a clinician's good practice, or in some instances where there are opportunities to provide better care and have better outcomes for their patients. We do look at preventive measures and measures that promote healthy living, that assist in better understanding of patients' overall health. Obviously, care coordination is critical for efficient care, better care, and certainly for the most economical way to deliver care. Of course, we're very interested in trying to reduce the disparities that currently exist in healthcare. These measures may or may not be publicly reported, but if they are publicly reported, we are looking to help consumers make informed decisions regarding the healthcare choice of their clinician or facility. So we do have a physician compare website, as you guys are aware, and we are posting more and more measures on the physician compare website, although we do not post first-year measures. So if it's a brand new measure being collected for the first time, we would not report those results in the subsequent year. Next slide, please. So you guys have probably heard the term the Meaningful Measures Initiative. And we're looking at meaningful measures to assess core issues that we as an agency consider most vital to providing high-quality care and improving patient outcomes. We do intend to prioritize outcome-based measures. We're trying to reduce the focus, if you will, on process measures. I'm not saying we're eliminating process measures completely, but we certainly prefer outcome measures, or at least process measures that are strongly tied to an outcome. So we define meaningful measures that focus on one or more of the following areas: high-impact measure areas that safeguard public health, patient-centered and meaningful to patient type measures, outcome-based measures, again, where possible. We're looking for measures that are relevant to providers. We want the measures to be something that represents the work that they and care that they provide, again, so it can confirm their good care or give them an opportunity for improvement. We are trying to minimize the burden for providers. I mean, obviously, provider needs to take care of their patient first and foremost. We have started to trim measures that have very high performance rates and or that are low value. We do prefer measures where, again, there's a significant opportunity for improvement. So if it's an important process or outcome, and let's say the average is 60%, well, clearly it sounds like there's an opportunity for improvement, as compared to something where their average performance rate might be 97%. It's hard to move that needle from 97 to 98 or 99, and it may not be clinically significant to do that as it would be, let's say, in another metric going from 60 to 80%. We are looking at population-based payment through alternative payment models. So we're looking at measures potentially suitable for that. And again, as I mentioned, we are trying to align with other payers, including Medicare here at CMS, but also the commercial payers. We've been involved with the Core Collaborative in the past and have adopted many of their measure sets. Next slide, please. So this is a pictorial of some of what we just went over. You guys have probably seen this slide already. Again, just at a high level, promoting effective communication and coordination of care that we just talked about, prevention and treatment of chronic disease, looking at communities to promote best practices of healthy living, things like smoking cessation, trying to make care affordable. So at the same time, looking at reducing wasted healthcare dollars. So treatments that are not recommended, overutilization, if you will, of certain tests or medications. Making care safer by reducing harm during the delivery of care, and strengthening the person and family engagement. So those of you that are clinicians on the call, the communication with patients is critical. You could be the best doc, but if you can't communicate with your patient and have them understand what they need to do and their caregiver, it gives new meaning to falling on deaf ears. Next slide, please. So the importance of QCDR measures. We're looking, of course, for them to be clinically relevant measures addressing gaps, as we already talked about. Could be for specialties, preventive care, or disease management. Typically, these measures are not contained in the annual list of MIPS quality measures. There's no sense in having a measure that is either very similar or identical to a measure in the MIPS program. Better off just reporting the MIPS measure itself. In that way, you'll have a larger cohort of clinicians that your clinicians can be compared to, and thus a better opportunity for more of your physicians to score better. You can imagine, again, you've heard me say this before, that if your docs are the only ones reporting a particular measure, by definition, some are going to be higher performers and others are going to be lower performers. Whereas if your QCDR and 5 registries are reporting the same measure, say, one in the MIPS program, all of your docs could be the superstars because there are other docs to which they're compared. Let's see. So QCDR measure can be a measure in our annual list, but if there's substantive differences in the denominator or the manner it's collected. So we may have a measure in MIPS that's only available for claims and registry reporting. However, if you specify that measure, obviously that would be a different. The measure itself would be different, and that could be a measure that we use. Again, it would EHR measure would of course have a different benchmark. I believe that's it for my opening remarks. Robin, I'm going to flip it back to you if that's all right.
All right. Thanks, Dr. Green.
Thank you.
Go ahead and move to slide 10, please. Here are some goals and objectives for this webinar, things we hope you'll understand at the end of the call. We want you to know that CMS and the PIMS team are here to support you in your developing QCDR quality measures and getting them through the QCDR self-nomination process. Next slide, please. In the next two slides are general requirements for a CMS-approved QCDR. The first bullet, participants. By January 1st of the performance period, have at least 25 clinicians submitting data to the QCDR for the purpose of quality improvement. That means for the 2019 performance period, you need 25 participants enrolled, and you're submitting data to you by January of 2019. For 2018, the year we're in now, you needed those 25 participants by January 1st of this year. This does not mean that all participants have to use the QCDR to submit MIPS data to CMS. The attestation statement. During data submission, attest that the results being submitted are true, accurate, and complete to the best of your ability. Data submission. Use a CMS-approved method to submit the data. For data validation, provide a written plan describing how data will be validated and submit the results of data validation by May 31st of the year after the performance period. Next slide, please. The QCDR requirements for quality measures are that you must submit at least 6 MIPS quality measures or a MIPS-approved specialty measure set. The 6 MIPS quality measures must include at least one outcome measure or at least one high priority measure. High priority measures are defined as an outcome measure, as well as appropriate use, patient safety, efficiency, patient experience, and care coordination measures. Next slide, please. In addition to the 6 MIPS quality measures or MIPS-approved specialty measure set, QCDRs may submit more of the MIPS quality measures and up to 30 QCDR measures. So at least 6 MIPS quality measures or a MIPS-approved specialty measure set and no more than 30 QCDR measures. This slide references 3 categories from which QCDR measures can originate. QCDR measures may be NQF endorsed measures. They may be current MIPS quality measures with substantive differences, as Dr. Green just mentioned, and we'll get into more about substantive differences later in the presentation. Or QCDR measures can be measures developed by boards, specialty societies, collaboratives, or large healthcare systems. Regardless of the category of origin, all QCDR measures must be submitted during the self-nomination period, and all QCDR measures will be reviewed by CMS for potential inclusion in the MIPS. Later in this presentation, I'll provide some scenarios pointing out items considered when the QCDR measures are reviewed. The 2019 self-nomination period is September 1st through November 1st of 2018. We encourage you to submit your self-nomination, including your QCDR measures, early to allow time for interaction should additional information be requested during the measure review phase. Next slide, please. I'll now hand the presentation over to Jocelyn, who will describe measure structure and analytics.
Thank you, Robin. Good afternoon. In this next portion of the webinar, we're going to take a deeper dive into the measure structure and analytics. The goal is to help everyone understand some of the requests that we've made in the previous self-nomination cycles, as well as provide information and guidance as you get ready for this upcoming self-nomination. Hopefully this knowledge will improve the process and efficiency and reduce that back and forth communication during the self-nomination period, and hopefully get your measure approved. So next slide. Oh, that's the right slide right there. Thank you. So to get things started, we want to first establish the basics of a good measure. And we'll definitely be taking a closer look in the coming slides. First, measures must be evidence-based and have an intuitive appeal or high face validity. It should make immediate sense to the eligible clinicians utilizing the measure, and of course, as Dr. Green mentioned, if publicly reported, it should make sense to the public as well. The next two items are related to performance data. Should have an opportunity for improvement and show variation across eligible clinicians, which we'll discuss in detail later. Next is responsiveness to improvement activities. This aspect of quality improvement is not often talked about, but is definitely important. If we're holding those eligible clinicians accountable for quality measures, there should be some sort of evidence-based improvement activities that would lead to improved quality. As you all are aware, MIPS requires eligible clinicians to attest to improvement activities, and we encourage these corresponding evidence-based tools and strategies to improve quality. It's not just enough to measure quality, but we should actually drive quality care as well. As measures are developed, we should also be thinking about related improvement activities to support the quality measures, which ultimately should be developed in parallel. As Dr. Green mentioned earlier, as he kicked off the meeting, measures should fulfill the meaningful measurement criteria or measurement gap. And then moving on, lastly, is limiting the burden of reporting. The measures should not be so complex that or paperwork heavy that it deters eligible clinicians from submitting the measure. And then next slide, please. As we touched on the previous slide, measures should be based on clinical guidelines and current scientific literature, but should not be based on controversial or new treatment methodologies. We do ask that any clinical guidelines are submitted within your self-nomination, and we really encourage that they be from a reputable source and be the most recent, typically in the past 3 years. And measures submitted in the self-nomination process should also assess a quality action with a known variation or performance gap. Again, any applicable performance data is appreciated when submitting your self-nomination. It helps us with this, the review process. There should be enough gap to demonstrate there is room for improvement. If citing data from literature, it should reflect the most recent or data or within the past 3 years. We actually have encountered submissions with literature and data provided back from the 80s, so it's just important that it's relevant. For QCDR measures, CMS has been considering top-up measures of like 95 or above. This isn't a defined in concrete, but is just sort of a consistent rule of thumb that we've been going by. Measures with high performance rates do not allow for real room for improvement for the quality, so these measures will likely not be approved. And lastly, if a measure or in regards to variation, performance variation allows deciles to be assigned based on the performance range. If performance measurement terms, a very high standard deviation or variation may indicate data collection issues, or it could be an opportunity for improvement. And we're hoping to address the opportunity for improvement. If a measure has a very low or very narrow performance range, it may be considered topped out due to that lack of variation. For example, if 100 clinicians submitted the measure and all had a performance rate between that 71 to 72% performance range, it'd be difficult to create a very meaningful benchmark. It would be hard to justify rewarding a clinician submitting a 71.6% compared to a 71.1 because it's only separated by that 0.5%. And this is a very important example to point out is we commonly suggest that measures should be harmonized with other QCDRs so that a larger cohort can be compared to one another, and this would may create a larger range for those meaningful benchmarks to be established.
Hey, Jocelyn, what slide are
Yep.
you on?
I'm on this slide.
Slide
Yep.
16. Okay, just wanted to make sure.
Yes,
Thank you.
Yep. Moving on to the meaningful quality action, the numerator or quality action should be considered meaningful and appropriate to the patient population. Measures that are non-meaningful or checkbox will not be approved. CMS requests that measures be focused on an outcome based, which we'll discuss later in the presentation. Next, measures should not be duplicative of existing MIPS or QCDR measures. We have published or posted the QCDR specifications on the CMS website on the resource library. This is something new for 2018, and we encourage all of you to review the specifications prior to self-nominating for next year or a new measure. If submitted, if you're submitting and we determine that it's duplicative or very similar to an already approved measure, we will likely ask you to establish or go reach out to that steward and ask for permission to use that measure. And so it may be advantageous to go review that sooner or later to allow that ample time to create, to start collaborating with those other QCDRs. We are excited to announce that you may have already heard that we are going to be launching a Google group for QCDRs to sort of collaborate and an open forum of new measure concepts. So that you'll find more information in the coming days on that. So lastly, measures should be beyond the conceptual state and have complete specifications. Ideally, this would include testing for validity, reliability, and feasibility, but this is not required for QCDR measures. So now, next slide. And we're on slide, yep, there we go. We'll now transition over to the measure construction. In the last review cycle, you may have received feedback from the team to form a composite measure. Composite measures are considered to be more robust as it requires multiple quality actions to occur. This allows assessment of a broader spectrum of quality care. A composite measure is a combination of two or more measures that result in a single score. This is a concern of a lot of the QCDRs, that performance data of the individual components would be lost in the shuffle. As a QCDR, you're still able to gather and maintain separate performance rates to provide that feedback to the eligible clinicians. And this would allow the identification for areas to improve upon. But for program purposes, CMS will be basing this, the score on that overall or indicated performance rate. Composite measures may be constructed in multiple ways. First, we have the all or none. This would require the eligible clinicians, eligible patients per se, to receive all of the quality actions to be numerator compliant. But on the flip side, there's also an any or none, which is similar, but it is used for adverse events. A patient is counted as failing if a patient experiences at least one of the adverse outcomes. For example, a surgical measure that assesses a rate of infection, readmission, and reoperation. If all of those adverse events were avoided, then that's when the eligible clinician would meet the intent of the measure. Next is the linear combination. This will calculate performance based on a simple or weighted average of the scores of each of the components. Lastly, regression composite performance measures will weight components based on the reliability and the strength to support or drive to that gold standard. And then next slide, please. Within MIPS, we have a number of composite measures. For example, 441 is IVD all or none outcome measure, or we have the immunizations for adolescents. Both are measures that require all components to be in compliance in order for the eligible clinician to be considered numerator compliant. For each of the quality actions, appropriate denominator exceptions should be evaluated unique to the quality action. For example, the first component within 441 is to assess the most recent blood pressure measurement. However, if the blood pressure is derived from the urgent care setting, this would be considered a denominator exception and would not be the blood pressure they'd use to determine the performance. The same denominator exception would not be appropriate for the other components. Therefore, it's only a numerator option for that first component. The immunization measure is a measure that ensures that all adolescents receive the appropriate vaccinations. The numerators are specific to the vaccine, the number of doses, and the appropriate timing. This particular measure requires for performance rate, but CMS will score the eligible clinician based on the fourth bullet, all patients who are compliant for meningococcal, Tdap, and HPV during the specified time frames. This would allow the eligible clinicians to evaluate their performance or lack thereof in each of the areas. For instance, if most patients were receiving the meningococcal and the Tdap, but the eligible clinician or group was falling short of providing that HPV, they could take a peek at their processes, their internal processes, to ensure that more of their patients were receiving that HPV vaccine. So next slide. Moving on to multiple stratum measures. The goal of multi-stratum measures is to reduce the number of measures addressing a similar condition or quality action. These measures contain multiple denominators but address a similar clinical intent. We are really wanting to have the same measures with the similar concepts be combined. An extreme example is having two pain improvement measures. I think Dr. Green always says one for their pinky toe and one for their big toe. That's not a clear indication of quality, or that shouldn't be separated into two different measures. We would definitely suggest those concepts be combined. And then each measure, each denominator can be limited to the appropriate patient population, and then the numerator can be adjusted for the denominator eligible population. Next slide. This is an example, measure 7. It's assessing the beta blocker for CAD based on the history of MI or myocardial infarction or their compromised LVEF. Each of the strata considers different risks and deeming it appropriate for that beta blocker therapy. Another option would alter both numerator and denominator, but are measuring similar concepts. For example, a measure developed to ensure diagnostic tests are read and communicated in an appropriate amount of time. Each of the denominators can be grouped by the diagnostic tests based on an urgency, but each of the numerators can be adjusted to align with the denominator. The numerator action for criteria 1 may be 4 hours, whereas criteria 2 is more urgent and only allows for 30 minutes to elapse before that communication should occur. If eligible clinicians submit a multi-strata measure, it would be anticipated that they submit all of the strata that they have denominator eligible encounters. Next slide, please. Now that we've discussed the composite and the multi-stratum measures, we will discuss the ways to crunch the numbers. For multiple strata measures and composite measures, we request that you indicate a method in which you determine the overall performance rate. This is the rate that we'll use for scoring purposes. It may be derived by a weighted average, simple average, or indication of a particular performance rate. First, weighted average is determined by summing the numerator counts of each submeasure and dividing by the sum of the denominator counts of each submeasure. So back to measure 7, combines the two criteria into one weighted average by adding the numerator compliant instances from both criteria and dividing it by all the eligible instances found in a denominator criteria. And of course, subtracting the denominator exceptions from the denominator when appropriate. Next is a simple average. It's determined by adding the percentages for each of the submeasures and dividing by the total number of components within each submeasure. MIPS measure 305 is an example of a simple average where the performance rates from each of the strata are added together and divided by the number of strata to create that simple average. And next slide, please. There may be instances where a weighted average or simple average is not the appropriate overall performance rate, but rather an indicated performance rate would be best representation. For example, MIPS measure 238 is a measure that assesses high-risk medication use within the elderly population. One numerator evaluates the use of one high-risk medication, and the second numerator evaluates if two orders of the same high-risk medication were prescribed during the performance period. The overall performance rate used for scoring is actually based on that first criteria or with first numerator because that is the more robust quality action. Keeping in mind this is an inverse measure, and the intent of the measure is to limit the number of high-risk medications to the elderly population. And now I did just mention inverse, so before we move on, for inverse measures, a lower calculated performance rate indicates better clinical care or quality or control. The performance not met numerator option is actually the representation of better clinical quality or control, and submitting that numerator option will produce a performance rate that is closer to 0. We do ask that all QCDRs designate which measures are inverse, and it is very important to capture this accurately. We could be unfairly scoring eligible clinicians if we don't have that appropriately designated. So just keep that in mind when submitting. And if you do have questions, please feel free to ask more about that. So now we can move on to the next slide, and we'll do a deeper dive into the measure analytics. And next slide, please. Measures may include circumstances where they may need to remove a patient from evaluation of the quality action. The timing of their removal would be dependent on whether it is an exclusion or an exception. Exclusions are more absolute, where the quality action is not applicable and would not be considered for a particular population. However, on the other hand, a denominator exception permits the exercise of clinical judgment and implies that the treatment was at least considered for the eligible patient. These are typically classified under medical, patient, or system reasons. For example, measure 318, this is a hypertension screening measure. Therefore, it would not be appropriate to include those patients that have already been diagnosed with hypertension. This patient population would be removed prior to the evaluation of the quality action, and this would be considered that denominator exclusion. However, there may be instances where the patient would be eligible for the measure, but circumstances may remove them from the evaluation of the quality action. For example, if the patient refuses or is an emergent situation, this would be the patient is appropriate for screening, but there's a reason documented for not completing that quality action, and that would be considered the denominator exception in this scenario. There are also numerator exclusions, which these typically apply to ratio and proportion measures that are inverse. and define instances that should not be included within the numerator data. In a ratio measure, an example of a numerator exclusion would be infections with a specific bacterium, and a measure that assesses central line bloodstream infections. For the proportional measures, numerator exclusions are typically used only in inverse measures where lower score indicates better quality. Next slide, please. All right, risk adjustment. You may choose to risk adjust your measures. This is a statistical process that is used to adjust for different patient characteristics before determining the outcome. This allows a more accurate comparison, or evens out the playing field, if you will. There is also an option to risk stratify. This is different from risk adjustment, but separates the outcomes within different groups. For example, we have a statin therapy measure 438 within MIPS that it creates different strata based on different risk factors. It'll take in consideration lab values, your age, additional diagnoses. So it's just important to know the difference there between risk adjustment and risk stratification. All right, next slide. Okay. Electronically derived measure requirements. We would like to bring attention to the electronically derived registry measures. While this may ease the burden on abstracting the data, it's imperative that vendors or QCDRs collaborate with the measure steward prior to creating an ECQM version. This is to ensure that work has not already begun on creating an ECQM, and so the appropriate coding is maintained. This specification must be a true representation of the measure's intent and produce valid data. This may have unintended consequences to the eligible clinician where the ECQM has a considerably lower performance rate because it was not completely capturing the numerator data. CMS would like all parties to be respectful of copyrights and intellectual property when attempting to adapt the measure to meet their needs of abstraction. We're not trying to reduce the number of EHR data mining, as this is definitely a valuable resource, but cautioning the creation of ECQMs that may not truly represent the measure's intent. We have received emails from concerned measure stewards that performance data is not aligning when abstracting manually versus ECQM. So just wanted everyone to keep that in mind. Next slide. Measures may be constructed as proportional, continuous, variable, or ratio. Proportional measures are most prevalent in MIPS. Proportional measures have a clear numerator and denominator. The numerator captures the quality action and is divided by the denominator eligible population. For example, we have measure 128 of the population, which would be the denominator. How many of those patients have received a documented BMI with a follow-up plan if required? Next slide, please. Continuous variable measures do not have your traditional numerator versus denominator format, but are evaluated on a continuous scale. MIPS has implemented a few continuous variables recently. For example, 461 average change in leg pain prior to lumbar discectomy or laminotomy. Performance is determined by the degree of improvement of the leg pain following surgical intervention. The measure does not have a set level of improvement required to meet performance, but rather an average. CMS recommends that measures within this contract show enough variability to support benchmarking. If the majority of the eligible clinicians all show the same average change of 1 point, this would not support that variability to establish those meaningful benchmarks. And it may be more appropriate to assign a threshold in order to meet performance. In this scenario, the numerator may be revised to state number of patients that reported a 2.3-point improvement following surgery, and that would create more of a proportion, or it would create a proportional measure at that point. Next slide. The last example we wanted to review was ratio measures. This score may have a value of 0 or greater that is derived by dividing a count of one type of data by another type of data. We see a lot of confusion between ratio and proportional, and they're not interchangeable. One element of the ratio is that the numerator is not in the denominator. For example, the number of patients with central lines who develop an infection divided by the number of days of central lines. When determining performance rates closer to 0 represent, or closer to 1 represent that expected outcome. In our example here today, we have the average length of stay for heart failure. The expected, and we just threw out numbers here, so this is not backed by any clinical guidelines. The expected outcome would, length of stay would be 4.5 days. When assessing this patient's stay, it was actually 5.5, which exceeded that expectation and produced a ratio of 1.2. So, and then next slide, and I will actually be turning it over to Stephen, and he's going to just sort of walk through some of the challenges in those non-proportional measures and how they relate to scoring. So take it away, Stephen.
Sure. Good afternoon, everybody. So I think as we were walking through with Jocelyn, you could kind of see how the delineation between these proportion measures and continuous variable measures become increasingly more difficult. So just wanted to walk through a few different items today as we look at it from a statistical nature as opposed from a clinical nature. So we can see that non-proportion measures include a variety of different data elements that are captured within the numerator. Because of this, the variability in the data becomes increasingly more complex and makes it very difficult to create any type of statistical model that would be able to give a relative outcome on the benchmark. Below are a few listed items that we've seen within the measures. So we have an average time in minutes, an average time in hours, change in outcome related to improvement test, length of stay, or a ratio. In addition to the variability, we would also be unable to determine if the numbers are truly reflected of the clinician's practice or quality. Outliers can have a large impact in modeling if not realized and adjusted. We would be unable to equate for and normalize the data based on practice size, physical location, general population, or risk adjustment factors that are outside of the actual measures themselves. Next slide, please. So based on this information, we consider you to be the experts within your medical communities and believe that you will have greater insights into the benchmarks related to these measures. As Jocelyn mentioned earlier, if we can revise the numerators to establish a benchmark based on guidelines or national performance data, this will actually create a proportion measure that will make it easier to not only track improvement, but also will give us a more standard guideline for creating statistical modeling related to benchmarks. We can utilize performance data to determine performance met or performance not met criteria. And this also makes it more reliable when we talk about the ability to see if there are outliers within the data that could potentially be normalized prior to creating the benchmark. So we can see that an example would be the door to balloon time. Continuous variable would just be a mean time from arrival to balloon, whereas if we have a proportion measure, we can say balloon time under 2 hours. And this would allow for the QCDRs to be more involved with the quality standards set by the measures that are being created. And that's pretty high level, trying to explain the complexities from our end of trying to make sure we accommodate all of the measures that are becoming available within the program. especially as we move towards more of a quality performance program where we're trying to assess better performance and better quality are the outcome for the measures. Next slide.
Okay, thanks, Stephen. Yeah, thank you so much. In this next section, we'll be moving away from the analytics and briefly touch on classifications of measure types and whatnot. So we can go ahead and go to the next slide. A process measure is promoting a certain process or quality action that may lead to an outcome. Within a process measure, the outcome is not absolute, but supported by evidence that that clinical process may lead to an outcome. For example, 226, the preventative care in screening tobacco use, where screening and cessation intervention. This is a process measure that promotes a specific screening and cessation intervention for tobacco users. If the process is followed, it may lead to decreased tobacco use. However, if the measure is altered to require that the patient stop tobacco use within a period of time, this would be considered an outcome, as the outcome would actually be the cease of tobacco use. So next slide, please. As I mentioned, an outcome is a measure that assesses the results or an outcome of a process. This could include clinical events, recovery, health status, patient experiences, efficiency, or cost. CMS promotes the use of outcomes over the process measures and encourage QCDRs to explore opportunities to create more outcome-based measures. For example, we have MIPS measure 181. This measures the success of cataract surgery and requires a specific level of visual acuity to determine if the cataract surgery was a success. Next slide, please. And next, we have efficiency and cost resource use. Efficiency is broadly defined as the cost associated with a specific level of performance with respect to the quality of safety, timeliness, effectiveness, equity, and patient-centeredness. The measure should be linked to a quality outcome as well as the processes that are required to achieve the outcome. This measure in our example addresses both the cost resource for low-risk prostate cancers, but also improves the quality of care as it addresses patient safety and effective testing. Next slide, please. And also, there are a number of measures that utilize patient-reported assessment tools. These may include pain or functional assessments to measure the success of a treatment or therapy. Please do keep in mind that measures that only capture that a survey was completed, we won't approve those. We expect that there should be some sort of improvement or positive outcome to demonstrate the quality action. This may include improved pain score, increased function, or the patients were satisfied with their care. I know we've held previous webinars addressing the functional outcome measures or the many functional outcome measures in QCDR within QCDRs. So we're just looking to get those harmonized. And then that is all I have. But before I turn it over to Robin, I want to mention we are nearing the end of the presentation, and we encourage you to submit questions for the Q&A portion of the webinar. So I will turn it over to Robin. Thank you.
Thanks, Jocelyn. I'm going to share with you some of the items that are considered when we do the QCDR reviews. Go ahead to the next slide, please, slide 38. One of the first things considered, and this won't come as a surprise as it's been mentioned several times, is the QCDR measure evidence-based? So are guidelines summarized and cited in the self-nomination submission? And does the measure submission include summarized and cited evidence of a performance gap? If these items are missing, you'll likely be asked to submit them in order for the measure review to be completed. Another thing considered is, does the QCDR measure address one or more of the 6 national quality strategy priorities? They're listed here on the slide, and a list to the Meaningful Measure Initiative that Dr. Green spoke of. Next slide, please. Slide 39. More things considered, and not in any particular order. I'm waiting for that slide to come up. In addition to being evidence-based and showing room for improvement, does the measure submission include evidence of variance in performance across the clinicians? That was also mentioned a couple of times. If not, we may ask you to provide that also so we are aware of what that information is. If there's a high performance rate and minimal variation across clinicians, the measure will likely not be approved. As has been mentioned, measures with high performance rates don't provide meaningful measurement or benefit to the patients or the clinicians. Also considered is, if implemented, could there be potential harm to patients due to an unwanted, unintended consequence? If so, the measure will not be approved. Likewise, if the measure's focus is for a topic that should never occur, those never events, the QCDR measure will not be approved. Next slide, please. Slide 40. Those are some more general things considered during the measure review. In the next few slides, we'll go over some more specific scenarios to kind of orient you to the format of the next few slides. In each bullet represents a scenario and then the typical CMS reaction or response. In the first scenario, if the QCDR measure submitted is similar or identical to an existing MIPS quality measure, CMS will ask you to report the MIPS quality measure. If the QCDR measure submitted is similar or identical to a retired PQRS, MIPS, or QCDR measure that was identified as topped out or as a standard of care, the measure will likely not be approved. In this next scenario, the QCDR measure submitted includes an NQF measure ID. Include the NQF ID only if submitting the exact measure specification as endorsed by NQF. If the specification is not exact, it won't be considered the NQF endorsed measure. And the last scenario on this slide, if the QCDR measure submitted is similar to measures submitted by another QCDR, meaning the intent of the measure is similar to that of other QCDR measures submitted, CMS may ask you to work with the other QCDRs to harmonize those similar measures into a single measure that can be used across the QCDRs. Measure harmonization between the QCDRs provides eligible clinicians a bigger cohort to be compared against for performance, scoring, and benchmarking. Measures should be harmonized unless there is a compelling reason for not doing so. QCDRs will be asked to provide detailed justification for having separate measures. Next slide, please. Some more scenarios on slide 41. If the QCDR measure submitted is identical to measures submitted by other QCDRs, CMS may ask you to get permission to use the other QCDR's measure. If the QCDR measure submitted is similar or related to measures submitted by the same QCDR, meaning you submit QCDR measures that are similar to each other, CMS may ask you to combine those similar measures into a broader denominator multi-stratum composite measure, as mentioned by Jocelyn a few minutes ago. If the QCDR measure is similar to a measure that was previously rejected, the measure will not be improved unless it has been modified to require a more meaningful quality action. If the QCDR measure submitted is an assessment measure, meaning the action is that the clinician completed an assessment, CMS will request that the measure be modified to identify the standardized assessment tool and that the treatment plan reflect the results of the assessment. Similarly, if the QCDR measure submitted is a patient survey measure, meaning the action is that the patient completes the survey, CMS will request that the measure be modified to be about the patient satisfaction or improvement in the patient condition. And as Jocelyn mentioned a few minutes ago, CMS will not approve patient survey measures that only measure whether the survey was distributed or completed. Next slide, please. And this is my last slide of scenarios. If the QCDR measure submitted quantify individual steps for a single quality action or delineate individual pieces of a specific procedure, meaning a single process or outcome is divided up into several QCDR measures, the QCDR will be asked to consolidate the related measures into a single composite measure. By consolidating the similar measures into a single composite measure, clinicians and groups are likely to have more meaningful data on which to improve the quality of care they provide. If the QCDR measure submitted is a continuous variable rate, while these measures are acceptable, as Stephen mentioned, they're difficult to work with for comparative purposes. The QCDR will be asked if a quality threshold can be set. If so, they may be asked to transform that measure into a percentage rate. If the QCDR measure submitted does not demonstrate room for improvement, CMS will request performance data from the QCDR to understand the analytic value of the measure. Specifically, is there room for improvement? Additionally, we will likely ask for variation in performance rates among the providers reporting a given measure. In the last scenario, if the QCDR measure submitted was approved the previous year and now has substantive changes that may not allow comparison to previous performance data, if approved, the measure will be identified as a new QCDR measure and assigned a different measure ID. Next slide, please. Slide 43. We'll spend a little bit on substantive changes. Substantive changes. This is specific to QCDR measures that were approved from the previous program year and are resubmitted during the self-nomination for the next program year with changes that may not allow comparison to previous performance data. Here are some examples of substantive changes. The care setting that was originally identified as with general E&M codes has now been changed to include anesthesia procedural codes. Or maybe the quality action was changed from the number of patients who had an assessment 2 months post-procedure to the number of patients who showed greater than 10% improvement in functionality, in functional ability 2 months post-procedure. And the last example is analytic designations have been changed. So if the measured designation hasn't changed, it was an inverse and now it's not, or proportional or ratio or continuous variable and or risk adjusted, and those have changed from the prior year to the next submission. That may impact the comparison of the previous performance data. CMS may ask about the measure designation if it is submitted differently from the prior or previous year to confirm that the QCDR measure has indeed been changed. If approved, CMS will consider the resubmitted QCDR measure with substantive changes to be a new QCDR measure and assign it a different measure ID. Next slide, please. Let's talk a little bit about provisionally approved measures. Some QCDR measures are provisionally approved, meaning they can be used for the performance period, but CMS is requesting performance data or modifications to the measure for the next self-nomination period. If you have provisionally approved measures for the 2018 performance period, the JIRA notification informing you of the provisional approval included a comment with the CMS request that's to be completed when you submit the QCDR for the 2019 self-nomination period. Here are the most common reasons for provisional approval. CMS wants to quantify the performance gap and room for improvement. With the notification that the measure is approved for the 2018, was provisionally approved for 2018, we ask for a summary of data, of performance data and clinician variance to be included with the 2019 self-nomination. Another reason could be that CMS request measures be combined into composite or multi-strata measure. Again, in that notification of the provisional approval for 2018, we identified the measures that should be combined for the 2019 self-nomination submission. CMS could be wanting to request collaboration with other QCDRs to harmonize measures, and we've talked about this before, being similar measures are coming in. Again, in that notification of the provisional approval for the 2018 period, we identified the QCDR measures to work with before the 2019 self-nomination submission. And lastly, CMS requests the measure be modified. Again, in that notification of provisional approval, we provided an example or suggestions of ways to revise the measure to be made before the 2019 self-nomination submission. If the QCDR measure that was provisionally approved is resubmitted during the next self-nomination period, part of the measure review is to determine if the request has been completed or if there is detailed justification as to why it was not completed. If the CMS request was completed and there is evidence of a performance gap or variation, the QCDR measure will likely be approved. If the CMS request was not completed, the QCDR measure will likely not be approved. Next slide, please. Slide 45. You've seen this checklist before. It's been revised a little bit as we interact with the QCDRs to get more and more detail onto it. But prior to nominating a QCDR measure, this checklist could be reviewed. CMS and the PIMS team use a similar checklist during our review process. This first slide, I'm not going to read it to you, and there won't be any surprises because these have all been covered during this presentation. This first slide is what the QCDR measure should do, and the next slide is the list of things that the QCD measure should not do. And we can go ahead and move on to slide 47. Here's the ones they should not do. And then the next slide, 47, please. In summary, for QCDR measures to be meaningful, they must not only address gaps in care for specialties, preventive care, and or disease management, they must also be clinically relevant, harmonized, and minimally burdensome to report. QCDR measures that are evidence-based with low performance rates and performance variation across clinicians provide meaningful measurement and benefit to the patients and clinicians. CMS welcomes the opportunity to meet with QCDRs to review, measure concepts, and provide feedback prior to self-nomination. The next slide, please. Got a few slides left just with some resources before we move to the Q&A session. Go ahead on to slide 49. As has been mentioned a couple of times, CMS welcomes the opportunity to meet with QCDRs to review, measure concepts, and provide feedback prior to self-nomination. To request a measures concept call, contact the QCDR vendor support at gdit.com site by September 1st. That's when the self-nomination period begins. Provide availability at the time of the request so we can get something scheduled. And then about a week, at least a week prior to that call, please send the concepts that you'd like to review so that CMS and the PIMS team can be prepared when we do have the call. Next slide, please. This slide, slide 50, has some more resources that can be used. Please note, as Jocelyn mentioned, the fourth bullet is the 2018 QCDR measure specification file. This is posted in the resource library. These are the QCDR measures for the 2018 performance period, and it's a good resource as you plan for your 2019 self-nomination. The resource library has additional reference material, and it will be updated this summer in preparation for that 2019 performance period. Again, that starts September 1st. Next slide, please. Also, I want you to be aware of the ECQI Resource Center. Those specific to electronic clinical quality measures, or ECQMs, it has many resources on measure development and implementation that may be of use as you develop and implement your QCDR measures. And finally, I want to call out the same thing that Jocelyn did, that we announced recently the QCDR Measure Development Google Groups Forum as a space for the QCDRs to collaborate on the QCDR measures. Look for announcements that it will be going live soon. Thank you for your time and attention, and I'll now turn the call back over to our moderator for the Q&A portion.
Thank you. We are now going to start the Q&A portion of the webinar. You can ask questions via chat or phone. To ask a question via phone, please dial 1-866-452-7887. If prompted, please provide the conference ID number, which is 2889118. Please note that we will not be answering questions related to 2018 participation in the merit-based incentive payment system. We will only be able to answer questions related to the development of QCDR measures. Also, we may not be able to answer all the questions submitted via chat. If your question is not answered, please contact the Quality Payment Program Service Center. So it looks like our first question here is from a hospital-based radiology practice, and they say there are some challenges meeting the volume when there are not enough measures to work with, so they're wondering when the list of measures will be expanded.
This is Sophia Sigmar from CMS, and I could take a stab at that question. So in addition to the MIPS quality measures that are available in the program, QCDRs have the ability to create measures that are more specialty-based. We find that a lot of specialties have developed their own QCDRs, which are qualified clinical data registries, in which they've come together and kind of develop their measures based off of the needs of their physicians that they support. And those measures are what they put forth during self-nomination, which occurs between September and November of a given year prior to the actual performance period. So for 2019, it would be September 1 of 2018. So the QCDR measures are an alternate to the MIPS quality measures, and they kind of the purpose of those measures are to kind of act as a supplement to for clinicians who believe that there aren't measures in the MIPS quality measure set that are available or applicable to them. So we encourage the use of QCDRs. If there are measures that you find that are not available in the MIPS quality measure list, I would suggest, if you would like to have an idea of what's available for 2018, to visit the QPP Resource Library. And under the 2018 page, there is a list of MIPS quality measures, but then there's also a list of measures supported by QCDRs that are currently approved for the 2018 performance period. And those are broken down by clinical topic. If you have any questions in terms of how to reach out to a QCDR if you're possibly interested in using their measures, we have a qualified posting that's also available on the resource library, which will provide contact information for all our approved vendors for the 2018 performance period.
All right, thank you. Our next question, this person's asking, to be able to submit QCDR measures, are we supposed to nominate ourselves?
Yes, only QCDRs can develop and submit for CMS consideration QCDR measures. So that would occur during the self-nomination period. I would just like to flag that we are going to have a webinar, a public-facing webinar on self-nomination. That would be later this summer. Self-nomination will occur between September 1 and November 1. And it's between that time period where you will be required, as you submit your application to be considered as a QCDR, that you would submit your measure concepts as well for CMS review.
Great, thank thank you. And this next question is, how does QCDR fit into the IQR program and measures?
I'm not sure that it does.
It
Go
doesn't.
ahead, Dan.
It does not at this point.
Great, thank you. For this next question, this person says, if a hospital owns several practices with varying numbers of physicians in each practice, does the hospital report this information for the practices? And if they report this information, is it reported as one practice or broken down by physical addresses and or specialties?
So I think this question is one we would defer to the service center. It's not related to QCDR measure development. It's related to submissions and participation. So if we can have the user or provide the user with that contact information, that would be great.
Great, we can certainly provide that. So for this next question, if a measure is for a clinician to make a referral to an intervention or a program, does the clinician have to recommend to a specific site and document which one, follow up and determine if the patient is actually enrolled? Please describe how such a measure should be operationalized.
So this is Jocelyn. I can take this one, I think. So I think it's dependent on the measure and how it's developed. So there are some measures that actually require that referral loop to be closed, but then there's also other measures where it's a referral to cardiac rehab or evaluation of some sort, but it just depends on how that measure is constructed.
Great, thank you. And Tammy, are there any questions on the phone at this time?
There are no audio questions at this time.
Okay, great. So the next chat question says, is there a difference between inverse and inverted?
This is Jocelyn again. Not that I am aware of. I just would say if the clinical action is where your performance level or performance is trending towards 0%, that'd be considered inverse. I'm not really familiar with the inverted term, but assuming that that lower clinical or lower performance rate would be higher clinical control, then yes.
Yeah, and I just to kind of tag on to what Jocelyn just said, I'm not aware of any inverted measures within the program. Everything that I've seen refers to them as inverse, so it would be difficult to actually give an answer without truly understanding what the question is.
All right, our next question is, does CMS require risk adjustment for QCDR measures?
We certainly would prefer risk adjustment, or the ability for you to risk adjust. That will probably be becoming more important in the future. So, especially for outcome measures.
Great, thank you. This next question is the numerator typically defined by the measure steward, for example, NQF or NCQA?
So typically, yes, the measure numerator is defined by the steward, but again, with QCDR measures, the QCDR is considered the steward most of the time. So, I mean, I guess it depends on the situation. If the QCDR is using a measure that is owned by someone else and has received the appropriate permissions, they would have to use the numerator as it was included in the original specification. If the measure is their own, then they are responsible for coming up with that numerator.
Thank you. This next question is, what is the difference between a registry submission and a QCDR registry submission?
So if an eligible clinician or a group uses a qualified registry, which is different from a QCDR in the sense where qualified registries are limited to only supporting either MIPS quality measures that have been reviewed and, proposed and finalized through rulemaking, improvement activities, or promoting interoperability measures. QCDRs are different in the sense where they are able to develop their own measures for CMS consideration, so that provides them with an opportunity to develop measures that address specialty concerns that their specialists want to be measured on that might not be reflective of the measures that are in the MIPS quality measure set.
Great, thank you. For this next question, this person says that they are concerned that their physician policy committee won't be able to schedule a CMS call before September 1st because they do not meet until August 10th through 11th. So they were wondering, will CMS take pre-submission measure reviews and discussions once the application period opens?
To request a preview, we just ask that request come in prior to the opening of September 1st of the self-examination process. So just make sure that you make that request, and we'll probably want to get that scheduled soon after just because it will start to get quite busy during the self-examination. So we just want to make sure we provide the opportunity to review and time with you. So just before that September 1st deadline.
Yeah, the other thing to remember is the closer we get to the deadline, the less of an opportunity the entity will have to make any revisions that may be required.
Great, thank you. This next question, this person says they're a dermatology practice with one full-time MD, one part-time MD, and one full-time physician assistant, and they reported MIPS through their EMR system last year. Does QCDR apply to them?
So they would not be able to qualify based off the way you described to be a QCDR themselves. However, we do have dermatology-based QCDRs available if they are interested in using a QCDR to report. We suggest they visit the resource library and look at our qualified posting to see what vendors are approved for 2018.
Great, thank you. And kind of a related question, someone asked, does this apply to practices that do not have 25 providers?
So the requirements to become a QCDR, the eligibility requirements, we specifically don't look to approve individual practices or individual clinicians as QCDRs. We're looking at larger entities, whether they be specialty societies, regional collaboratives, or larger healthcare systems. If there's a larger healthcare system that manages multiple smaller practices, that might be something we also consider. But standalone practices are not ones we would typically approve to be a QCDR.
Great, thank you. This next question, this person says, at the kickoff meeting you indicated that we can start to work with you on new measures. Who at CMS should we communicate with as we work on developing these new measures?
So as Jocelyn and Robin have indicated earlier, we do have these measure concept preview calls that are ongoing now, and we've been meeting with QCDRs as they've come and approached us. So you can email the QCDR vendor support email address. I think it's in an earlier slide. It's qcdrvendorsupport@gdit.com, and provide them with your availability so we can schedule a call. They will ask that you provide measure concepts a week before the call for us to review.
Great, thank you. This next question says, most of these measures appear to be focused on primary care. How are specialists able to qualify?
I guess the question is more of how specialty societies can qualify to be a QCDR. That's what I'm going to interpret it as, because specialists as an individual clinician wouldn't qualify to be a QCDR. So if a specialty society is interested in becoming a QCDR, I would encourage you to visit our resource library, which would have a self-nomination fact sheet as to our requirements of what you should have and our expectations of your qualifications prior to self-nomination. We will post additional resources for 2019 as to how to self-nominate, a user guide that will give you screenshots and step-by-step steps that will show you how to complete the form and submit that. If you are interested in also developing measure concepts and submitting those, we will provide you with templates and ask that you complete all that and submit all that information by the November 1st deadline for consideration for the 2019 performance period.
Great, thank you. This next question is, when CMS is reviewing measures, how much time do CMS staff give measure stewards to make revisions and or attempt harmonization?
Some of that's dependent on, when we receive the measures. Certainly if it's submitted the last day, we do try to give you as much time as possible. Jocelyn, maybe you can, if they're looking for an exact number of days, maybe you have that.
Yeah, so I think we do 5 business days or 5 days when self-nomination is, and that's why we're sort of trying to do sort of some preemptive harmonization and giving you guys tools to review current QCDR measures, providing that Google group to forum to discuss new measure concepts with other QCDRs. So we're trying to give all the avenues to get that done prior to self-nomination. So, but typically when we make a request to revise, it's depending on the timing of it, it's 3 or 5 days.
But also, to add to Jocelyn's point, that all is dependent on how major the harmonization is. So if it's something minor where it's just an age range and we feel that it could be something that could be done within the time frame that Jocelyn specified, then that's one thing. If it's something larger, we also provisionally approve and then ask for harmonization by the next self-nomination period. So it really depends on the situation.
Thank you. And Tammy, do we have anyone on the phone with a question?
You do have a question from the line of Julie Marhalik-Helms with Napa Anesthesia.
Hi. Thank you for taking my question. I was just curious as to whether or not a single specialty group with multiple TINs can create their own QCDR.
So we are generally looking for a QCDR to be either a regional health collaborative, a large hospital institution or health system, or a specialty society. We'll be happy to consider other folks, but that's in keeping with I think how we've defined QCDRs. We won't have a single practice, if you will, QCDR. So I don't know if that answers your question or helps you.
To add to what Dan's point, we do have specialty societies that are anesthesia-based that have their own QCDRs that are available for reporting. I think the concern with having smaller practices developing their own QCDR comes to the volume of operational requirements that we have in the program and whether those can be met and the registry and technical submission requirements that we have and whether those aspects can also be met. So our preference is to typically go with the larger for those reasons, just because they have the means and the resources to meet all our requirements and participate and kind of meet those program requirements that are required throughout the year.
So just to make sure I'm clear, if there's, say, 2,000 providers that would be reporting, does that meet that threshold, or would that still be considered a single practice even though there's multiple 10, 11, 12, 10s reporting?
Mm-hmm.
Well, we wouldn't consider it necessarily a single practice, but would you be submitting your own measure suggestions, for example?
We probably would apply for a couple of maybe 2 or 3 QCDR measures, but then also reporting MIPS measures and some of the other specialty QCDR measures. So, for example, some of the QCDR measures that are already approved by CMS, we would just ask permission to report some of those as well.
Okay, just out of curiosity, why wouldn't you just go with an existing QCDR that's already reporting that?
Right now, we are just assessing the feasibility, so it's just really kind of a research period for us. But cost and ease.
Yeah, I mean, part of what we're looking for is we're looking for QCDRs to have the medical expertise, certainly for their measure development. I mean, at this point, we're not requiring NQF endorsement, for example, for the measures. But we are trying to raise the bar on the measures that we consider for QCDRs, so that they become a bit more comparable to the measures that we approve in the actual program.
So we've been reporting through one of the QCDRs in our specialty. We were just assessing the feasibility of starting our own.
No, I understand, and I'm letting you know. I mean, you can imagine, for example, a specialty society. I mean, they, generally speaking, are staffed with care experts that may or may not have the time, or they can convene the right people to actually develop the measures. And I guess what I'm getting at is we're looking for the measures to again be more robust and I'll say higher bar, more meaningful and appropriate. So sometimes that does, and often that requires a certain level of measure expertise. And I guess one of the concerns I would have from what you're describing is, would you all have that?
Mm-hmm. Okay. So maybe just a separate discussion offline.
Sounds like a plan. Thank you.
Thank you.
All right, our next question is, are we able to offer a measure pending approval to other QCDRs for submission with their application?
Yes, you can do that. So if it's pending approval, it hasn't been assigned a measure ID yet. So we would just have to know, those other QCDRs would have to note in their QCDR measure template that the measure belongs to you and that they've received the appropriate permissions. Now, we don't get involved, CMS doesn't get involved in terms of the process of seeking permission. We leave that to the QCDR legal teams and what you feel is appropriate in order to give and receive that permission. We just ask that it be done by the time of self-nomination.
Thank you. Our next question is, what about measures that gather treatment and outcome data when there is a gap? The measure is designed to measure outcomes of treatments for development of clinical guidelines.
That would be more of a research or experimental use, and while certainly data collection vendors and registries certainly can do that, that's not necessarily something that we would include in our QCDR measure collection, for a host of reasons. Some of them have to do with, I imagine that, again, if there are different treatment modalities looking at outcomes, some of that would probably need to go through an IRB at an institution. And at the same time, we're looking for best practices, not so much for experimental measures.
Okay, thank you. Our next question is, if we don't submit any new measures for QCDR, but we'll be leveraging existing NQF and HEDIS measures, Do we still need to self-register for these specific measures to be certified?
So if you want to, yeah, no problem. If you want to support measures that are not included in the MIPS quality measure list that is finalized through rulemaking, then yes, you would have to self-nominate those measures. So if they're NQF endorsed, we need the NQF ID numbers. If they're not NQF endorsed, that's not needed. If the measures do not belong to you, we need to know who they belong to. As appropriate, you should get permission from those stewards. We do not want there to be, intelligent or, copyright issues, and you might have stewards that are not too happy if you don't seek their permission prior to using the measure. So that is something we would ask you to consider before you self-nominate measures, that you take the appropriate steps to make sure you're able to use them.
But if you're not planning to submit any of your own measures, you may consider trying to become just a registry. The requirements would be a little easier for you. And then, as a registry, you could report any measures in the MIPS program. If you're talking about reporting, as Sophia was alluding or discussing, if you're talking about reporting other QCDRs measures, then you would need to be a QCDR, again, as Sophia said.
Great, thank you. And I think for this next question, we'll go back to slide 38. Deirdre, if you could move that back to that slide for us. So this person would like some elaboration on cost reduction.
Cost reduction? Could you repeat?
Oh, yep, go ahead.
If you understand that,
I think they just wanted some clarification on what we're meaning when we want to measure cost reduction. And so it's, say for instance, like repeating the same MRI 3 times just to, that's going to be very costly. And so measures that reduce that or address overuse would be considered cost reduction measures.
Great, thank you. And this next question is, if you are requested to consolidate measures into a composite measure, will that measure now only count for one measure?
Yes.
All right, and Tammy, do we have anyone on the line with phone questions?
There are no audio questions at this time.
All right, thank you. Our next chat question is, when will the new blueprint be released?
I think that's something we'd have to follow up on because that's not a publication that we manage.
Yeah, and I think, to Sophia, to add to that, we will be publishing a handbook that it's not a replacement to the blueprint, but definitely will give a lot of additional feedback and information when creating your measures.
Yes, and that handbook is specific to only QCDR measures.
All right, thank you. This next question is, do you envision any changes to the QCDR vetting process due to the upcoming CMS MACRA Measure Development Cooperative Agreement Awards? And this person's asking specifically to how far along a concept or measure needs to be in order to be submitted for consideration.
I don't know that we're anticipating any change. We would, the requirements of QCDR measures would be as they are finalized in the final rule. So if it's not in there, we couldn't hold them to more stringent standards.
Thank you. This next question says, we are advised not to submit documentation / checkbox as a QCDR measure. What does this mean, and can you give an example of this?
Yeah, so when we say it's a checkbox measure, say for example, it would be the patient was assessed for depression. the depression screening tool indicates the patient is depressed, but then just doing that quality action and no follow-up, no plan of care, that would be considered a checkbox where you're just doing the assessment, there's no quality action associated.
All right, thank you. For this next question, this person says, there are a number of MIPS measures, for example, MIPS 431, alcohol screening and intervention, that have only outpatient E and M codes that would also be highly relevant and meaningful for inpatient encounters providers. Is it possible to submit these measures as QCDR measures with the relevant inpatient codes? And if not, do you have a recommendation?
I'm sorry, can you repeat the question one more time?
Yes. So this person says there are a number of MIPS measures and lists MIPS 431 alcohol screening and intervention as one example that has only outpatient E/M codes that would also be highly relevant and meaningful for inpatient encounters providers. Is it possible to submit these measures as QCDR measures with the relevant inpatient codes? And if not, do you have a recommendation?
I can take this one if you'd like.
Go for it.
So if you're wanting to expand the setting or the clinical setting that's not found within the MIPS, by all means, you can definitely submit that. We do, however, try to take that feedback back to the measure steward. So for instance, if it was measure 431, we might go back to the measure steward and request that they add those in a subsequent performance period. So that clinical setting is represented within the MIPS measure as well. So you can still do that. It is important for us because when we look at that measure, we're going to say, well, this is duplicative. So when you self-nominate, I would definitely include that within your denominator or some sort of indication that this is not a duplication of the MIPS measure, but expanding the clinical, because then we will probably come back and be like, well, what's your coding and whatnot. So having that extra information would be helpful.
All right, this next question is, does CMS provide guidance on risk adjustment to assist measure developers?
I believe that there are some. Sorry.
Well, NCQA, I think, has. Go ahead, Sophia.
And I think in either the blueprint or another measure-related resource on the on our CMS website, there is a section about risk adjustment of measures, but I'm not sure if the level of detail there will cater to the person's question. Dan, what were you saying? Sorry.
I was going to say, I think NCQA also has some information, but if you have difficulty after checking those places, you can certainly let us know, and we'll try to get you some information. Find some other places to get you information.
Okay, this next question is, what is the process of requesting to use a measure from another QCDR? Is the decision to approve solely on the other QCDR?
So if you're interested in, like, let's say for 2019, you're interested in one of the existing 2018 measures, QCDR measures that have been approved, those QCDR organization names and through the qualified posting, those points of contact with their contact information is available for you to, start that reach out early and be proactive. If for some reason you are aware of, and if it's not posted, a measure that's not posted but is in the process of being submitted and it's one you're also interested in submitting, we would ask you that you include that measure in your template, recognize who the steward is or the QCDR is that's the original owner of the measure, and that you've gotten the appropriate permissions. If for some reason we reject the measure in the original submission from the original vendor who owns that measure, the same rejection would apply across the board. So it would not be available for anyone to report if the owner of the measure cannot report it.
Thank you. This next question is, can you elaborate on the following measure review consideration? Measures that are never events will not be approved.
This is
Sure.
Robin. A never event example could be surgery performed on the wrong patient. Dr. Green, you probably have some more examples, but you certainly would never want those to occur, so we wouldn't want to be measuring those.
Things that occur too infrequently to really distinguish, Dr. A is providing better care than Dr. B. Fires in the operating room should never happen, but the chances, you may never have one in 5 years. Maybe the year you have it, it's terrible, but your numerator count or failure count at that point would be 1, and somebody else would be 0. So we couldn't really compare or have deciles to assign points. And we all agree it should never happen, and all precautions should take place to prevent it from happening. But it happens so infrequently, it's not a good quality metric for the program.
Thank you. This next question is, what are the options if a QCDR doesn't want to share a measure? And if we want to modify or harmonize and stratify the measure, do we need permission?
So again, as we, go
ahead. No, you go ahead.
So as we indicated earlier, we definitely highly encourage harmonization and collaboration between the QCDRs. We would not approve duplicative measures that were just one off from one another. So in any case, if you are reaching out to a QCDR and they're unwilling to work with you, we ask that you let us know so that we can kind of reach out and find out why. We would then, as a part of our QCDR measure review process, review both concepts and would probably pick the better of the two.
Thank you. This next question is, what's the best way to understand what provisionally approved measures may undergo harmonization for the next performance period?
This is Robin. Is the question that, if the question is that how do you know which measures were identified as being requested to be harmonized, in the JIRA comment that provided the status that it was provisionally approved, for example, for 2018, it would request that you work with QCDR X, Y, or Z to harmonize the measure for the next performance period. So the measure as well as the other vendor, the other QCDRs, would be listed in that comment.
All right, thank you. This next question is to please define participants.
Do we know what they are referring to when they say participants? Is it the 25 participants in the registry? If it's that, then we're. Oh, sorry. So if we're referring to the 25 participants a QCDR must have, we're asking that the entity that's developing this QCDR they should be able to submit and receive data from eligible clinicians. So when we say participants, we're referring to the physicians or groups that you can actually accept and receive data and have the ability to transmit data. This is more of showing that you have that technical experience and you have experience with registry collection. You kind of have to demonstrate that to us as a part of your self-nomination. We expect that vendors would have experience doing that.
Great, thank you. This next question is, when does the nomination period open for QCDRs for 2019?
The self-nomination period will open September 1, 2018, and will close at 5 p.m. November 1st. So during that time, we will have it open. It's a web-based tool. Further instructions are forthcoming. We will probably release those instructions later later in the summer, and we will have a webinar to go along with it. That will be sometime in August.
All right, this next question is, can an electronic health record apply to become a QCDR?
I guess I'd have to take a look at whether or not they met our requirements of QCDR participation, and we would kind of have to know why. I mean, because EHR is a submission method under MIPS, why they would actually want to be a QCDR instead.
All right, this next question is, when you self-nominate to become a QCDR, do you have to list out every already approved measure you might potentially report on?
So if this is a question from an existing vendor, yes. You have to, as a part of your self-nomination process, list all the ones you've been approved for. We do reevaluate the measures on an annual basis.
Great, thank you. And Tammy, I just wanted to check in to see if we have any questions on the phone.
And there are no other audio questions.
Great, thank you. And as a reminder, if you would like to ask a question via phone, please dial 1-866-452-7887 and press star 1 to be added to the queue. So this next chat question is QCDR just the quality reporting measures for MIPS eligible providers?
So QCDRs are used for the purposes of MIPS, yes. They can report on quality measures, develop their own QCDR measures, support improvement activity reporting, or support promoting interoperability measure reporting. So they can do either all of those or some of those. We do ask that they definitely support at least 6 quality measures, whether that be QCDR measures or MIPS quality measures or a mix of both.
Thank you. This next question is, how does the QCDR fit into the greater CMS landscape?
So QCDR is an organization that can report quality and potentially, if they so choose, interoperability data as well as improvement activity data for purposes of our, for purposes of the quality payment program. They also can be, hopefully they're in the business of quality improvement independent of CMS. So, but in terms of the CMS landscape, they do, we would expect them to partner with medical experts, either a specialty society, again, regional health collaborative or large health organization, so that the data and the metrics they're collecting, fit our meaningful data and are well vetted in terms of their appropriateness.
Thank you. This next question is, for our provisionally approved measures, it was requested to provide performance data for consideration for the 2019 performance period. How is this done?
Yeah, so when you go to self-nominate this next year, we ask that it would be included within your self-nomination. Yeah, and you're right, you probably don't remember seeing that field. Part of that self-nomination process for 2019 will be updated. We're continuing to trying to improve our processes on our site as well. So as you submit your self-nomination, please include it. And that would include your performance rate, the performance rate range, as well as the number of eligible clinicians that are included within that data.
Thank you. This next question is, composite measures are not required, correct? Only one high priority or outcome measure?
That's correct.
All right, and the next question, this person says, please remind me of the criteria that needs to be met to use a measure that is not in the MIPS list.
So I believe we have a previous slide that kind of outlines what we're looking for in terms of QCDR measures, that they not be standard of care, topped out, meaning there's high unvarying performance rates, that they don't reflect documentation or checkbox, that they actually show or can measure quality improvement, not duplicative of any existing measures that are already in the program, not duplicative of existing approved QCDR measures. I refer back to those slides and our self-nomination fact sheets as they come out this summer to help you make sure you meet all the criteria as you have prepare your measures for self-nomination.
All right, thank you. And Tammy, I just wanted to check in again to see if anyone was on the phone.
There are no phone questions at this time.
Great, thank you. All right, so this next question is, will there be notification of what measures may be harmonized?
I believe that's a follow-up from a previous question regarding provisional approval and the request for harmonization. So each year or each self-nomination, if it is determined that the harmonization is too great or that it's going to be too cumbersome to accomplish within the short amount of time within self-nomination, we may request, we would give you feedback via JIRA that it's provisionally approved for the year. However, during the next self-nomination, it would be expected or anticipated that the measure be harmonized with the other QCDRs that are submitting a very similar measure. But yeah, there will be notification which measures should be harmonized.
Great, thank you. And it looks like there are no longer any questions relating to this webinar in the chat box, so we will just pause for a couple minutes to allow for any last-minute questions. And just as a reminder, we are only able to answer questions related to the development of QCDR measures.
So last call for questions, folks.
We did just get one question. If a QCDR resubmits a measure in 2018 that had been approved in prior years, would we need to submit new clinical documentation?
Not necessarily, unless the information previously submitted has changed. Or is outdated. By outdated, we're thinking more than 3 or 4 years old.
All right. Thank you, Dr. Green. And Tammy, do we have anyone on the line?
There are no audio questions.
Is that it, operator?
There are no audio questions at this time.
Okay.
And there are no more questions in the chat.
Okay. Well, timing is everything, guys. So to our participants, kudos to you, because we're just about up on time anyway. I do want to thank folks for dialing in, and I also want to thank them also for the thoughtful and good questions that were asked. We hope you found this helpful. As we mentioned early in the call, we have had kind of one-on-ones with QCDRs that are planning self-nomination or to re-self-nominate to review their measure concepts if they had concerns. And that is open to everybody. So just wanted to reiterate that. For those of you that are already QCDRs and or registries, we will look forward to speaking with you on our monthly support call, which will be coming up a little bit later this month. So thank you again, and have a great afternoon and a terrific summer. Good day.
This concludes today's conference call. You may now disconnect.